dyspnea in patient in ER, differential diagnosis and most useful diagnostic testing. Dyspnea are shown as is common and often distressing symptom in patients presenting to the emergency room. A methodological approach to differential diagnosis and diagnostic testing is crucial for effective management. Differential diagnosis: asthma, symptoms: wheezing, cough, chest tightness, variability of symptoms, pathophysiology, airway hyperresponsiveness leading to reversible airflow obstruction, chronic obstructive pulmonary disease, progressive dyspnea, chronic cough, sputum production, pathophysiology, airway limitation, QT bronchiolitis and emphysema, pulmonary embolism symptoms: sudden onset dyspnea, pleuric chest pain, tachypnea, pathophysiology, obstruction of pulmonary arteries by thrombi leading to impaired gas exchange, heart failure symptoms, dyspnea on exertion, orthopnea, paroxysmal nocturnal dyspnea, pathophysiology, cardiac dysfunction leading to reduced ejection fraction and fluid overload. Pneumonia symptoms: cough, sputum, fever, pleuritic chest pain, pathophysiology, infection of the lung parenchyma leading to inflammation and consolidation. Pneumothorax symptoms: sudden sharp chest pain and dyspnea. Pathophysiology: air in the pleural space leading to lung collapse. Anemia symptoms: fatigue, pallor, and dyspnea on exertion. Pathophysiology: reduced oxygen carrying capacity of the blood, anxiety disorder, symptom dyspnea, palpitation, chest discomfort, often in the absence of organic pathology. Pathophysiology: psychological factors leading to hyperventilation and sensation of shortness of breath. Most useful diagnostic tests: medical interview and physical examination, identifying risk factors, symptoms pattern, and associated symptoms. Examination of respiratory and cardiovascular symptoms, pulse oximetry, purpose: assess oxygen saturation. Chest X-ray indication: most cases of acute dyspnea. Purpose: identify pneumothorax, pneumonia, heart failure, and other structural abnormalities, and electrocardiogram ECG indications. Suspected cardiac causes of dyspnea. Purpose: detect arrhythmia, ischemia, or signs of heart strain. Complete blood count, specific indications: suspected anemia or infection. Purpose: evaluate hemoglobin level and white blood cell count. D-dimer indicating suspected PE with low to moderate pretest probability. Purpose: rule out PE in low risk patients. CT pulmonary angiography, CTPA indications: high clinical suspicion of PE. Purpose: direct visualization of pulmonary arteries. Green natriuretic peptide or N-terminal pro-B type natriuretic peptide, anti-pro-BNP indications: suspected heart failure. Purpose: biomarkers for cardiac stress and heart failure. Spirometry indications: suspected asthma or COPD. Purpose: assess lung function and reversibility of airflow obstruction. Echocardiography indications: suspected heart failure or other cardiac abnormalities. Purpose: evaluate heart structure and function. High endpoints. Pulse oximetry is a quick and non-invasive initial test for all patients with dyspnea. Chest X-ray and ECG are essential baseline investigations for dyspnea in the ear. CTPA is the gold standard for diagnosing PA, but is indicated based on clinical risk assessment. BNP and pro-BNP levels are helpful in diagnosing excluding heart failure. Spirometry is key for diagnosing asthma and COPD, but may not be feasible in active severe dyspnea. Differential diagnosis table: asthma, wheezing, variability of symptoms, spirometry with bronchodilator response. COPD, chronic cough, sputum production, spirometry. PA, sudden onset pleuritic pain. D-dimer, low risk. CTPA, high risk. Failure, arrhythmia, PNE, ECG, BMP, Pro, anti-Pro BMP, echocardiography, pneumonia, productive cough, fever, chest X-ray, CDs, heavy drugs, sudden and sharp pain, chest X-ray, anemia, polypeptic CBC, anxiety, palpitation, chest discomfort, clinical diagnosis at the exclusion of other causes, in summary, a structured approach to history, physical examination, and judicious use of diagnostic tests are essential for effectively managing dyspnea in the emergency setting. So, yeah, let's talk about dyspnea in the patient. Dyspnea in the patient in the art for diagnostics for diagnostic testing. Differential diagnosis, asthma, COPD, PE, heart failure, pneumonia, pneumothorax, anemia, anxiety disorder, and most useful diagnostic tests, medical interview and physical examinations, pulse oximetry, chest X-ray, echocardiogram, complete blood count, D-dimer, and CT pulmonary angiography. High clinical suspicion of PE, PDPMP, brain natriuretic peptide, or N-terminal pro-beta natriuretic peptide and pro-BMP, spirometry, echocardiography, high-point pulse oximetry, chest X-ray, ECG, STPA, PMP, NDPA, pro-BMP, spirometry, differential diagnosis, asthma, COPD, PE, heart failure, pneumonia, pneumothorax, anemia, anxiety. And then let's move on to the next question. Clinical presentation. Tristin, dyspnea, sympathetic activation, cardiovascular symptoms, atypical presentation. ECG finding, ST elevation, pathological QA, residual change, T-wave changes, high down point time is muscle.